Dr. Puchalski directs the George Washington Institute for Spirituality and Health at the George Washington University School of Medicine and Health Sciences in Washington, D.C. She is also an assistant professor of medicine and healthcare sciences at George Washington University. She received her Master's of Science degree in biology from UCLA, and she did doctoral work in biology at the Johns Hopkins University before receiving her MD from George Washington in 1994. Until earlier this year, Dr. Puchalski served as Director of Education for the privately funded National Institute for Healthcare Research. The Nathan Cummings Foundation and the Robert Wood Johnson Foundation have supported her research on end-of-life care, and she has received grants from the John Templeton Foundation for curricular development. Dr. Puchalski also current research focuses on evaluation of the effectiveness of spirituality and medicine courses in medical schools, end-of-life training in clergy education, the role of spiritual assessment in patient outcomes, and spiritual intervention as a component of the care of nursing home patients. Today she will talk to us about the role of spirituality in health and illness. Thanks. I think you must.
Let's see. Like that? Okay. Can everyone hear me? Okay. Thank you very much. And I do want to also thank the John Templeton Foundation for sponsoring this lecture. And also I would just like to take a moment to honor one of my colleagues who's been very instrumental. He was a very close friend of mine and a mentor, who Dave Larson, who sadly died in March. But Dave, at the age of 54 years old, Dr. David Larson was a psychiatrist who pioneered a lot of the research in the area of religion and health in the States. And when I was a medical student, I actually developed one of the first courses on spirituality and health, and Dave spoke in that course. And subsequent to that, he and I worked together over the next 8 years developing a national program for medical education. And so I'd really like to dedicate this lecture to my friend Dave. And today what I'm going to do is to talk a little bit about what we're doing in the United States with regard to integrating spirituality into healthcare. Over the last 10 years, there's been an enormous change in the way that we're training physicians. And in that, we are now teaching courses on spirituality and health. Back in 1992, as you can see from the slide, there were only about 3 schools with courses. My course at George Washington was one of the first around that time. I will say, though, parenthetically, there had been courses in the Catholic medical schools on religion and on ethics, however, not specifically looking at how one would integrate spirituality into health care. So these were a little bit different. Now we have over 70 of the medical schools teaching courses, and many of these courses are required. They're not elective courses. And so there's been a phenomenal change again in what we're teaching and in how we're teaching. And what I'm going to do in this lecture is to give you the background, some of the data, but some of the ethical principles as to why we're teaching these courses, and then finish off with telling you how we do a spiritual history and how we actually integrate this practically into the healthcare professions. The John Templeton Award gives grants to medical schools, and I do want to say we've been trying to get Canadian schools and residency programs to apply. This is a program I direct at the George Washington Institute for Spirituality and Health. And yearly we give, it's a competitive award program, we give grants to undergraduate medical schools for developing curricula on spirituality and health. Those are 4-year programs. And then we have 1-year awards for psychiatry and also for primary care residency, primary care being internal medicine and family practice. And next year we're starting one in OBGYN. So these programs are open to Canadian programs. So if you're involved in any kind of training up here in Canada, please talk to me afterwards and I can give you some information. I think that's one reason that there's been such an explosion, because of our interest in certainly the program that I developed in spirituality and health. But another really is a recognition that we need to move to a more compassionate model of care. Now, when I started doing this 10 years ago, I definitely saw a trend in the States towards this more compassionate model. In fact, if you just look at palliative care and the model of palliative care, these are the precepts: to pay attention to the physical, emotional, social, and the spiritual dimensions of our patients, not just the physical. And at that time, I thought, well, by the turn of this century now, this would be well ensconced into our system of healthcare in the States. However, it hasn't yet taken a hold, because I think for many, many reasons. I think in the late in the 50s, 60s, and 70s, there was this booming of technology which tended to fight against some of the compassionate element, the art element of the practice of medicine. And now we're dealing with the business of medicine, and the fact that doctors and nurses, and I understand that it's the same here, see patients in such a brief amount of time that in many ways I was reflecting on what Gandhi said Thursday night. I think our system of medicine is really violent in that we don't really take the time to listen to our patients. So many of us who are doing this work are really also working on a political level to change our system of care so that the spiritual issues of our patients can be taken care of as well. The Association of American Medical Colleges is an organization in the States having to do with making recommendations and projecting trends to medical schools for teaching physicians. And in the late 90s, they started a study looking at what was being taught in our schools, what were the key elements to be taught, and what should be deleted and what should be added in the curriculum. The first report, which this is excerpted from Report 1, lists the attributes that we felt that physicians should have when they graduate. The third and fourth attribute had to do with being skillful and knowledgeable. The second one was being dutiful, but the first one was this one, and that is that physicians should be altruistic. And it goes on to say that we need to be compassionate and caring for all of our patients, and in all of our interactions with our patients, we should seek to understand the meaning of the patient's stories. And this is where the spirituality comes in. How do we understand what gives meaning to our patient's life? How do they understand their illness? How does that impact the meaning in their lives? So again, in the meaning of their stories in the context of their beliefs, family, and cultural values. And it ended with saying that we should continue to care for our dying patients even when disease-specific therapy is no longer available or desired. And while that all seems pretty self-evident, in fact, in practice, it's very, very difficult. Where in the States, because of insurance requirements, et cetera, many times physicians can't follow their patients into hospice or into caring for them till the end of life, and a lot of patients feel abandoned by that. And again, we're trying to change that model to bring back some of the roots of our profession where patients can see the same doctor over their lifetime, have a good relationship with their healthcare providers, and continue to be cared for them even to the very end. Part of this speaks to the need to change the focus of training from a curative focus, that is that diseases you expect to diagnose them correctly and cure them. We do hope for that. But in most cases, people go on with chronic lifelong illnesses and eventually die from that. And much of our education system doesn't support that, and so for young medical students coming out of medical school, going into residency, are not equipped to really partner with patients through the chronic process, through suffering. And Rachel Naomi Remen, how many of you have heard of her or read any of her works? Yeah, she's a physician in California who herself is a pediatrician, suffers from a chronic illness herself and has worked with cancer patients and has established a beautiful retreat center north of San Francisco called Commonweal. And it focuses on doing retreats for patients with cancer, and now she's doing retreats for physicians as well. But what she talked about in her first book was the difference between helping, fixing, and serving. And she said that when you fix, you see life as broken. When you help, you see life as weak. But when you serve, you see life as whole. And so she challenged us to think about what our work really is as servers of humanity, as servers, as taking care of other people, and that really is the work of the soul, whereas fixing and helping may be the work of the ego. So many of us who are trying to bring back that service component to our profession are trying to, in essence, I feel very strongly, in our earlier presentation, you were saying that we're just spiritual people. Well, I think everybody is a spiritual person, and I think the work that we do as caregivers, not just physicians, but all of us in the caring professions, is spiritual work. We are helping other people. We are being of service to others. So how is it that we can say those things in our own personal lives? I feel that very strongly in my personal life, but then I go into the professional environment, the high-stress clinic where I see patients every 10 or 15 minutes, and everyone's anxious and everyone's angry and everyone's frustrated and people are tired of filling out forms. How do we then bring that deep spiritual calling that we have to help others into a system that may not be so friendly to that and may not support that? That's really our challenge. The American College of Physicians convened an end-of-life consensus panel, which I was part of, 2 panels actually. And the first panel in 1998 just looked at what the role of physicians would be in terms of suffering of their patients. And this group felt that it was so important to deal with all dimensions of suffering that they actually came out with a consensus report. And this just summarizes one of their findings, that we as physicians should extend the care for those with serious medical illness by being attentive to the psychosocial, existential, or spiritual suffering, as well as other types of suffering. And I think this is, while this was a physician panel, this is clearly true of all of us in the caring professions. I teach an end-of-life class to my second-year medical students, and a very important person that's always involved in co-teaching it with me, I spend about 15 minutes, but the rest of the hour and a half is taught by a patient who is actually dealing with a chronic and terminal illness. And the very first time we taught this, one of my patients with breast cancer spoke to my class, and one of the students raised his hand and said, I understand that religion's important to you, you're an Episcopalian, I know that going to church is important, but why not just deal with those issues with your priest, or even with the people that go to church with you? Why is it that I, as your doctor, would have to know this? And she said, because if you are my doctor, I want you to know who I am. I want you to know what makes me tick. I want you to know what makes me think. I want you to know what makes me feel. I want you to know how I'm coming to terms with my suffering. And that is what spirituality is about. And she went on to say that every single person in the caring profession should deal with that. The nurse, the lab technician, the social worker, the chaplain, everyone should deal with that dimension of their patients. And she noted that actually it was the housekeeper in the hospital late at night when the hospital was short-staffed and people didn't have time to listen to her, but the person who came in and emptied that trash can while she was crying and sat next to her and held her hand and prayed with her or listened to her, whatever they did together, that was so important for her and so healing. And so she said, every single person who deals with me as my caregiver needs to be aware of that dimension. In an earlier talk, we heard that in fact there are requirements for pastoral services. We get accredited by JCO, and there is a requirement that hospitals provide spiritual care services to patients when requested. I know this very, very intimately because our own hospital did not have a chaplaincy program for a long time. It did have spiritual care in that it had volunteers providing spiritual care. But chaplains really are trained very specifically to be able to deal with spiritual issues that arise in the healthcare setting. And in fact, a clinical pastoral education trained, CPE trained chaplain can work with people of many different spiritual beliefs, religious and or otherwise, atheists, agnostics, and others. So when I refer to chaplains, I really want to refer to someone that has had that kind of training. So many of us, myself, but many chaplains are actually moving to make these requirements even tighter, to have pastoral care departments led by certified chaplains, not volunteer clergy only or volunteer lay people, but actually by chaplains as well. Well, how is it that spirituality plays such a significant role? In this whole conference, we've been talking a lot about meaning and personal meaning in people's lives. And I come at it from the perspective of spirituality is that which gives a person deep meaning in their life. Foglio and Brody are medical ethicists who in 1988 wrote an article on this issue for the Journal of Family Practice. And what they said is that for many people, religion, and I broaden that to spirituality, forms the basis of meaning and purpose in life. And that illness can cause us to question that very thing that we thought gave us meaning. So for some of us, our meaning can come from our profession, our marital status, or economic status. But what if we become really sick and we can no longer work? Or as some of my patients, their relationships, their marriages fall apart because of their illness. What then gives your life meaning? And that's really what we're talking about when we talk about spirituality in the clinical setting, that it is in the context of illness, the reason the person is coming to talk to you, or health, their general well-being, that maybe some of these issues get raised. The last sentence, healing the restoration of wholeness, as opposed to mainly technical healing, requires answers to these questions. And this gets back to what I was talking about when we talk about cure and care. Cure certainly may involve technical healing, but care and dealing with the chronic illness and finding some sort of healing in the midst of that, I believe, comes from the spiritual realm and from dealing with these questions. So what are the types of questions? I'm an internist and a geriatrician. I do a lot of end-of-life work, but I care for patients across all ages in adult life. But because of my practice and perhaps because of my interest in spirituality, many of my colleagues tend to refer very chronically ill patients. So most of my patients are very close to death, or certainly dealing with very severe chronic illnesses. And in as much as they want to know about the technical aspect of their illness, what their breast cancer diagnosis means, what are their treatment options, etc., it's just as important for them that I be attentive to these kinds of questions as well. Why is this happening to me? Basically, existential type questions. I go on rounds with my residents in the hospital, and oftentimes my patients will ask that first question on rounds if we're dealing with a person with a very serious diagnosis. And it never ceases to amaze me how many residents answer that in a biological way. Well, the reason you have cancer is because your mother had breast cancer, your mother's mother had breast cancer. We know it's familial. And there's a tendency for us to be comfortable in that with which we were very well trained, which is the physical aspects of illness. But really, when a person is asking a question like that, it's a really rhetorical question. It's an opening to a larger discussion. And there's so many missed opportunities when people ask us questions like that and we move on or move away from it. And I suspect part of it has to do with our own inability to deal with that question ourselves. But when we move off to some area like the physical or run out of the room, it's really an amazing missed opportunity, because patients will often clamp down after that and may not want to share in these things. And that's why I think it's so important for every healthcare provider to be able to be sensitive to these issues and to be able to talk to patients about that. Being missed, being remembered. Larry Vandercreek is a chaplain in the States who's done a lot of research on death transcendence and has found that most of us want to be remembered somehow. And so again, themes of being remembered, of having importance in life, of having meaning in other people's lives come up a lot. I adjust therapy with my patients to help them accomplish dreams. I had one woman with sickle cell anemia who died in her early 40s, and for her it was very important. She had very, very young nieces and nephews, and she had promised that she would take them to Disney World. And as her illness was progressing, it became apparent she might not be able to do that. So we adjusted all sorts of therapies that she was going through at that time so she could make that trip to Disney World, even at the cost of perhaps dying sooner. But she wanted to accomplish that because she knew that would be significant. For people that believe in God, not uncommon to question God's existence and to maybe even stop believing in Him. Many of my patients will be afraid to talk to their clergy people about this or their church members because they think they will be judged negatively. Yet they feel comfortable with me because I'm not perceived of in any particular religious affiliation. And so again, opportunities to talk about this with your patients. A lot has been mentioned about Viktor Frankl at this conference, which is delightful. Most conferences I go to, many people don't even know who he is, so it's great that there's such an honoring of this man and his work. And he's really talked a lot about suffering and how people may not be destroyed by suffering, but they can be destroyed by suffering without meaning. And even though our patients may not be going through something quite as dramatic as what he experienced during World War II, every type of suffering that our patient encounters is going to be devastating for that person in their life. And how is it, again, that we can help them find meaning? Again, when I talk about this with my medical students, their inclination in sort of this fix-it mentality is to think that we can assign someone meaning, and of course, that's not possible. But I think we can support people in their search and give them resources and direction. You'll be hearing tomorrow evening from a colleague of mine, Harold Koenig, who's going to talk to you a lot about the data on spirituality and health, and mostly on religion and health. When I first started teaching these courses, in order to get the interest of the deans, the data did play quite a role, sort of a door-opening role. Well, if they're doing research on it, it must have some sort of validity. But I will tell you that over the years, the data has also come under quite a bit of questioning and scrutiny. But in addition, it's not as important anymore. The data is not really what's driving the courses, but what is driving the courses are ethical principles of our obligation to patients and what we do in the context of that. And so in terms of ethical issues of why spirituality comes up in the clinical setting, one is that it may be a dynamic in how people understand their illness, people talking about meaning of their illness and what it means to them. Religious convictions and belief may impact healthcare decision making. And I see this over and over and over, particularly around end of life, whether people choose to be on ventilators or not, whether people choose to have transfusions, blood transfusions or not, feeding tubes, decisions around rituals performed in the hospital, how after death a body should be handled, and are there any particular rituals in cleansing of the body, and how quickly the body needs to be removed from the hospital, etc. All these decision making can be affected by religious beliefs, by cultural beliefs, and it's important for us to be aware of that. Spirituality may be a patient need, and I'll review a little bit of data on that, and important in patient coping as well, in coping with their stress. And finally, I think it's integral to whole patient care, and I'll talk a little bit about that more. In terms of a dynamic in how people understand their health and illness, many of my patients, and this was alluded to at some earlier talks as well, many of my patients see their illness as a punishment from God. And in fact, particularly with people who have HIV, a lot of issues about that, lung cancer, guilt that it may have been caused by their smoking and therefore they deserve to die. And I would say in many of those cases, patients don't want to seek treatment because they feel that their illness is deserved, and they become very depressed and despondent. And so unless we can address those issues in the clinical setting, our patients may not want to continue working with us or with other healthcare providers. Ken Pargamet has done quite a bit of research on positive and negative religious coping. And he's found that patients tend to show less psychological distress if they can seek control through a partnership with God or a higher power as they understand it in a problem-solving way. So as opposed to thinking that I'm a victim and anything that happens, I have nothing to say about it, but to be able to be a little bit more proactive and interactive. asking God's forgiveness and trying to forgive others. A lot of data now on forgiveness, but also just patient stories as well. Being people who hold on to resentment tend not to do as well. And particularly in light of September 11th and a lot of fear and resentment that people have, which unfortunately in the States is really driving people apart, a lot of racism and prejudice and fear. To be able to think about how might we on a global level forgive each other and forgive ourselves, and to be able to move on and forgive past hurts. Finding strength and comfort from one's spiritual beliefs. Again, people tend to show more positive coping if they're able to do that, and then finding support from a religious or spiritual community. In terms of negative coping, people tend to have more depression, a hardness towards other, and poor quality of life. Looking at quality of life measures in patients, if they see the crisis as a punishment from God. And this is what I encounter actually quite frequently in my clinical practice. I practice in Washington, D.C. I see a wide range of patients, but predominantly in inner city population, high population of crime, people who've experienced crime and abuse in their life, people who are, for the most part, I would say, Protestant Christian, and a lot of not their church communities as well are telling them that their illness is a punishment. An example recently, a patient of mine with diabetes who's having a difficult time controlling his illness, and he thinks it's because he's not praying hard enough. And how do we deal with something like that? My inclination, of course, is to say I don't think that's the case, but this is such a heartfelt belief for many of my patients. It takes time to work through that, and I work very closely with chaplains and other spiritual directors in these issues. Excessive guilt, an absolute belief in prayer and a cure, and an inability to resolve that anger when cure does not occur. Again, something I encounter a lot. And that creates often a great deal of tension between the medical staff and the patient and their family. Because the medical staff are coming at things only from scientific data, and the family is coming at it from another experience of a belief in a possibility of a cure. And when that doesn't occur, the communication, people are talking on two different levels, and can often end up in a lot of hostility. So to be able to respect people, and to respect that for many people have experienced cures in their lives, or certainly have a strong felt belief in that, and then to help them turn that around with the situation that they're encountering, again, the situational meaning. And then refusal of indicated medical treatment. I think that everybody has a right to refuse treatment. That's all of our inherent right. But I hope when I work with my patient that those decisions come from a point of informed consent. And so as a physician, I try to provide the medical informed consent, if you will. What will happen if one accepts a certain treatment and if one refuses a certain treatment, to the best of my knowledge. But there's also something as a spiritual informed consent. And we heard earlier that not all spirituality is necessarily good spirituality. And so, and not all people understand the dogma from their religious traditions. It may be misinterpreted. So I try to work again in conjunction with chaplains who can again work on spiritual informed consent with many of my patients. In terms of having importance for patients, there have been numerous surveys done in the States looking at how important the role of spirituality is. This was a study at the University of Pennsylvania. 66% of people in this pulmonary outpatient department, so they had predominantly emphysema, chronic obstructive pulmonary disease, chronic asthma, lung cancer, 66% agreed that a physician's inquiry about their spiritual beliefs would strengthen their trust in their doctor. Now, I have found from anecdotal evidence, I teach a spiritual assessment tool around the country, and in getting feedback from physicians and other healthcare providers who do this, people tell me that they feel their relationship, that the rapport between themselves and their patient is better, that they feel a more trusting relationship, and patients note the same thing. and this data seems to support that. This study then divided patients who said, yes, spirituality is important for me, for those that said it isn't. 94% of the patients who said that it was important said they wanted their doctors to address it and be sensitive to their spiritual beliefs. 50% of those patients for whom spirituality was not particularly important, half of them felt that at least doctors should inquire about spiritual beliefs in the case of serious illness. And yet only about 15% of those patients recall whether anyone asked them if their beliefs would influence their medical decisions. And this in a population of patients where the need to have resuscitation, et cetera, might be pretty likely, was rather surprising. By the way, my handouts were delivered to Trinity College, but they never got here. And all these slides and information is on that. So if you want afterwards, you can give me your name, or I can pass a piece of paper around and we can have them mailed to you. And also I will give you my web address at the end. My slides are up on our website as well, so you don't have to worry about going through all the details. George Gallup did a random poll survey in the States looking at what people would want if they were to be dying. And the top two concerns, he asked about social concerns, economic concerns, et cetera, pain management. The top two concerns were companionship and spiritual comfort. Companionship in statements like, I don't want to die alone, I don't want to be alone, and spiritual comfort, receiving a blessing from a clergy or a family member, having rituals performed at the bedside, listening to music, having time to pray alone or meditate. Those types of things were very important for people. In terms of coping, numerous studies on coping. And again, a lot of these had to do with religiosity, and just more recently are we beginning to look at spirituality instruments to look more carefully at the role of spirituality. These were 108 women undergoing treatment for GYN cancers. When asked what helped them cope with their cancer, 93% said their spiritual beliefs. 75% actually noted religion specifically having an important place in their life. 49% became more spiritual after their diagnosis. I had just gone to a workshop earlier in a study on HIV, and I think the population was different, but in her population, about 75% of the people did not identify themselves as religious, and 41% said they became more spiritual after their diagnosis. So there was a slight difference in that population. But in many studies, that third bullet down, 49% becoming more spiritual, that it's usually between 45 to 60% in the studies of people saying to a variation on this theme, becoming more spiritual, becoming more religious. And I think, again, that's because illness is causing us to question some of those issues of meaning and purpose in our life. Coping with advanced cancer. These are patients in a hospice in Burlington, Vermont, and quality of life measures were administered, looking at life satisfaction, et cetera, as well as pain instruments. And the pain scale was really rating your pain on a scale of 1 to 10. Patients who scored high on a spiritual beliefs index also had more life satisfaction, happiness, and interestingly diminished pain. I do a lot of palliative care, and the issue of use of narcotics used to be very big in terms of legal issues, and now it's still a problem because many patients do not want to be heavily narcotized, and yet they'd like to be pain-free. And while we can give people huge doses of morphine and not kill them, that does affect their alertness, and many people would like to be present. And in many religions, it's actually very important to be present at the time of death, particularly for Muslims. They want to be very aware at the time of death so they can say a phrase as they greet Allah. So how is it that we can manage people's pain adequately, yet respect a lot of their other wishes about how they would like to be present to others or to God, however they see that? So looking at spirituality, and here again very broadly defined, Could be spiritual measures such as meditation, yoga. Some people would argue that's spiritual. I think it's quite spiritual. Prayer, even alternative therapies, looking at those as adjuncts to pain management is a very active area of research. This was a pain questionnaire that was sent out by the American Pain Society to people who were hospitalized, not necessarily dying. And people were just asked to score what they're using for pain management. And as you can see, majority use pain pills, but then personal prayer came up at 76%. So again, a lot of people, and relaxation was down at 33%, touch and massage lower. So again, people are looking into what this means. We're actually trying to tease out prayer because that tends to be a very Christian approach. Not everybody prays. Yeah?
Was that a check-off list or spontaneous suggestions of what they were using?
Check-off list. There were more. I didn't add all the other items. There were a whole lot of other ones. Guided imagery was on there, music, yeah. But they came up much lower. So anyway, there's a criticism that prayer may really just reflect Christian practices, that in other religions you don't think of praying for something necessarily, although people have argued that. So people are repeating this now, looking at many different dimensions of spiritual practices. Finally, in end-of-life research, we look a lot at quality of life, and Balfour-Mont here, of course, in Canada, is a big expert in this area, and on his instrument and others, what the spirituality domain is really what's called the existential domain, which measures purpose, meaning in life, capacity for personal growth, and self-transcendence. So 3 items on that particular instrument correlate with good quality of life for people with advanced disease. One is if they find their personal existence meaningful. So what we're talking about this whole conference. If they find some fulfillment in achieving their life goals. And finally, if life to this point is worthwhile. So if you want to talk with your clients about spiritual issues or meaning issues, these 3 items may be a good place to start. Do you find meaning in your life? Tell me about your life goals. Do you have any? Do you feel you have some fulfillment in this area, etc.? I think there's a whole body of research, and I don't have time to do it justice, on the mind-body connection. Herbert Benson, my colleague at Harvard, and others have done a lot of work. Beecher was someone scientist in the 1950s who looked at the placebo effect, which is an inert substance. And he found that it was effective in 35% of the cases of a lot of things that he studied. Seasickness was big back then, I guess. And in fact, now we use placebos to test specific drugs. So we say, ibuprofen is effective in 70% of the population for pain management as compared to 35% in placebo. But if you think about an inert substance affecting even 35% of the people, this is the power of belief being so powerful. So that has led to a lot of research since then. And one of it has to do with meditation. Herb Benson has looked a lot at meditation, studied it for the last 30 years, and has found that it's a beneficial treatment for a variety of conditions. And is now doing a tremendous amount of work on the actual biochemical pathways in the brain that mediate the placebo effect and what he calls the relaxation response or meditation. And they're finding that nitrous oxide, which is a neurotransmitter, may be the common pathway for a lot of the actions that we're observing. And then Harold Koenig, who will speak tomorrow night, has looked at immune system functioning and has looked at something called interleukin-6, which it's a protein factor that's high in stress and also in disease. And now he studied 1,700 older adults. This was in North Carolina, so predominantly Protestant Christian and some Jewish, and has found that those that were attending church were half as likely to have elevated levels of IL-6. So he's hypothesizing that something about religious commitment may be helping people with stress management, and it could be with perhaps better coping mechanisms, a richer social support, strength of personal values and worldview. I think it may have to do with meaning. In fact, I'd love to repeat this study instead of just looking at religion, but looking at people in terms of personal meaning. Is it that people who have a deep sense of personal meaning also have lowered levels of IL-6? So I think it's important that we explore this a lot more. So if we just look at, again, a holistic approach, that spirituality may really play an important role in just good holistic care, how we care for ourselves and how people are able to heal from their illness. So what do we teach our students in medical schools? Why do we say spirituality is important? Well, I really focus a lot on coping and on how people cope with stress and chronic illness. And spirituality may help people cope with helping them with hope. And initially, we all would hope for a cure, but when that is no longer possible, what else do people hope for? For healing of another type, for healing of relationships, for acceptance, for peaceful death, for finishing important goals. And I think religious traditions give people a language of hope, but it can be beyond religion. Spiritual beliefs, community, other types of languages, being present in the moment, those types of things can really help people. Sense of control. The 12-step program is a very big program with us in the States, and many people feel out of control because of their illness, and yet by the language they use, turning things over to a higher power affords people a different type of control. So for some people, spirituality, religion may offer a sense of control. Acceptance, this is my lot in life, or there's a reason for this. And again, I think that goes along with Frankl's finding meaning in suffering, finding a meaning in the situation may lead to an acceptance to it. I am doing a study with HIV patients in collaboration with Joel Savat, who does a lot of quality of life work at the University of Cincinnati. And we're looking at the role of spirituality and the will to live in HIV patients. It's a big NIH-funded study. Prior to that, he did some focus groups with his HIV patients, and these were some of the comments that his patients made. My illness made me look at life a lot differently. People who are not HIV positive don't have the appreciation for life that we have. I need to contribute. I'm here on earth for a purpose. Talk about meaning and purpose. For people that were religious, they talked about faith in God helping them out. Prayer, my life is the best it has ever been. And my colleague Joel is a very quantitative person. He also expected people to be very negative about their illness. And so when he got these types of studies, results, he was very, very surprised that people could actually see positive experiences with their illness. I wasn't. In my clinical practice, I see this more often than not. And it is, to me, I'm constantly in awe every day that I go to the clinic or to the hospital of the strength that people exhibit in the face of devastating illness and in the face of their own dying. To be able to somehow see an opportunity out of it. Some of my patients call their illnesses blessings. And it's not for everybody, and it's not that it's always happy. Obviously, there are difficult times. But that in the midst of it, people can find that sort of meaning. And I just hope that we can provide a healthcare system that allows those of us who work with patients to give them that time to find that sort of sense of meaning. I can guarantee you if we shuttle patients from one doctor to another, from one specialist to another, from one test to another, the attention that they can spend on these issues will be minimized. And I think it actually has to be increased. So again, the need for interdisciplinary teams, chaplains, etc. So what is spiritual care from our perspective as healthcare providers? Not as chaplains per se, not as theologians, not as priests, rabbis, etc., but as people who deal with patients who are ill. I think the first is, and I borrow this from the Buddhist tradition, is the practice of compassionate presence. How can you be totally present to the person you're caring for? And this, in the face of being rushed, of dealing with pressures, is not easy. And in order to do this, I think it takes a certain amount of awareness of yourself And in many of the retreats we do with physicians and other healthcare providers is to really help people understand how they can support their own inner life and their own sense of meaning and purpose to be able to do this. So what do we teach? Well, in the ideal world, in some of my courses at school, we actually have meditation groups or spiritual support groups that students go through. We can't require that, though, so that's not part of the required curriculum. Physicians are flocking to that as well. You know, in the States, because of everything that's happening with our insurances and the conflict in our healthcare systems, et cetera, doctors are losing a sense of personal meaning in their profession. And so physicians, because of that, are now really flocking to retreat groups and support groups and meaning groups and all sorts of things. Rachel Naomi Remen has a package on meaning support groups for physicians to deal with just this type of thing. I think an integral part of this is being able to listen to every dimension of our patient's life. And if we think of what we've learned in our various professions, whatever you represent, we learn how to do a standard history, and we learn how to ask questions and get information. It's very different from what our patients want us to do, which is to sit and listen and be present. Obtaining a spiritual history, I'll talk about that in a minute. Being attentive to all dimensions of our patient's life and their family life. Incorporating spiritual practices as appropriate. I do teach an outline. I wouldn't go so far as to say it's meditation, but I teach what's called the relaxation response, which is how someone can focus on their breathing and then apply that, and they practice it. And I also refer a lot to people who are very interested in yoga and other types of spiritual practices, or chaplains, or if people are very religious, they want to explore that more. And we talk about that a lot in the clinical setting. And probably the most important bullet up there is to include chaplains as members of interdisciplinary teams. Now, I don't know what the atmosphere is like in Canada, but I can tell you in the States, most people don't know what chaplains do. And when I refer a patient to a chaplain, that patient usually turns to me and says, "Doc, is there something you don't know? Am I dying?" Because most people think that you go to a chaplain just when you're dying, last rites or whatever, you know, they think. And in fact, chaplains are just great resources throughout any part of an illness or throughout life. And so again, we use chaplains in our medical schools. They co-teach many of our courses, and they're a great support to our students because they, through their training, learn how to do the things I've just talked about up there, being present, listening skills, etc. So what is a spiritual history? And this is something that I've developed and we've now incorporated it into our curriculum. Physicians and nurses and others learn a sort of standard history format. And we've integrated now the spiritual history into that format. So I advocate that we do this at the initial visit when you first meet your patient, your client, that you do that, and we have something called a social history, so it's part of the social history section. That's the social history is what I call the patient-centered piece, really. It's to find out about your patient, what they do, what kind of work they do, where they live, do they have hobbies, do they have any spiritual beliefs that help them, what gives them meaning in life. I think it helps us recognize cases to refer to chaplains and other spiritual directors and counselors. At the very core, it opens up the door to conversations about values and beliefs. And so when I talk about spiritual history, it's synonymous with a values history, or if people want to use the word meaning. I'll tell you why I called it a spiritual history and not a meaning history. Because for a while, my colleagues in end-of-life care were asking people what gave their life meaning. And most people, when you ask that, they're not quite sure what you mean by that. Well, I work, you know, or I like to go to the football game, and people don't often respond very well. It's a very esoteric question. But asking someone if they have any spiritual beliefs, that's sort of a buzzword now that most people can relate to. And And I'll go into this later. If people say they don't relate to spirituality or religion, I then ask what gives their life meaning. I like what I heard earlier about personal meaning, to talk about what might give someone personal meaning in life. That might hone that down. But meaning is a very, very broad term. I think when you do a spiritual history, can reveal positive and negative coping that people have, that if you don't ask, you might not find out about that important dimension. And at the very core of all of this, I think it's an opportunity for compassionate care. After all, we're really trying to respect all dimensions of people. And I think that our interacting with others is a very spiritual interaction. And in being able to do this, we're able to give loving and compassionate care to our patients. The acronym that I've developed, and again, medical students like acronyms, and so I tried to come up with something that would be brief. This is not a religious assessment that people do, that chaplains do. This is meant to be a very brief introductory part of an overall history. And on the next page, and again, the handouts have that if you're interested, and also our website. So the F is sort of an opening question. And the question I use is actually the second one up there. Do you have spiritual beliefs that help you cope with stress, or is there something with this illness that you're going through? I think it's important that the context of this is, a history is in the context of someone coming to you as a professional, not as a professional chaplain, but as a professional healthcare provider. So I try to relate the questions to that. If people say that spirituality is not important, religion's not important, I ask what gives their life meaning. I then listen. The I is really listening to how important these beliefs are. For many people, that may be the very central core of who they are, and for some people, depending on their stage in life, it may not be. It is in the context of I that I ask about influence. So I ask about, are there particular beliefs that you have that might impact healthcare decision making? I get advanced directives or living wills during this time, ask about healthcare proxies during this time. So I think as we're talking to people about their values, the very values of who they are, it's a more natural lead-in to then talk about, if you weren't able to speak for yourself, do you have a proxy that could represent you and your wishes? C is really the extrinsic expression of that belief system, which is a community, a spiritual or religious community. And again, it's not necessarily church, temple, or mosque. It could be like-minded friends. So again, to be very broad and about thinking about this definition. And then A is to be thinking really how you need to address those concerns. Now, for some of my patients who are dying or who are dealing with a lot of acute stress in their life, these issues come up over and over and over and over. For other people, the most that it comes up again is that I'm connecting and I'm empathic to my patients, but it's not that it's an ongoing issue. So again, it's tailored to your patient's needs. In terms of ethics and professional boundaries, Stephen Post and I wrote a paper on this. It's very, very important that this is not an opportunity for proselytizing or for forcing beliefs, or similarly, atheistic physicians who think religion or spirituality is important, that they keep that to themselves as well. This is really about a patient-centered interview. What is important to your patient, not to you? And we can talk about that a little bit more if we have time. Just to close, I convened a conference with the Association of American Medical Colleges to develop learning objectives for teaching these courses, and these are the basis of our courses that are taught throughout the states now. And the first had to do with a definition of spirituality, and I gave it a 2-hour time slot in our meeting, and it ended up going all day, because the definition of spirituality, as you can well imagine, is very, very rich and complex. But this is the one we came up with, and again, is in the context of a clinical setting. So spirituality is recognized as a factor that contributes to health, and we wanted to say health, not illness, in many people, that it's a concept that's found in all cultures and societies. It's expressed through the individual search for ultimate meaning through participation in religion, but it can be broader than that, and or belief in God, family, naturalism, rationalism, humanism, and the arts. So again, how one finds meaning is beyond, can be very much beyond religion. And that all these factors influence how patients and healthcare professionals perceive health and illness and how we interact with one another. So we don't just take it as here's the patient with their spirituality, but we also have a spirituality, and there's a relational component to this, and that brings it back to the service component of our profession. The outcome goals, the overall outcome goals are that students are going to be aware of the need to incorporate spirituality into the care of patients in a variety of clinical contexts. So they learn this with case-based teaching. That they recognize that their own spirituality might affect the ways they relate to and provide care for patients. That they'll be aware of the need to respond not only to the physical needs that occur at the end of life and in life in any illness, but also the emotional, social, cultural, and spiritual needs that occur. And we've developed learning objectives which are available on our website, which is www.GWish.org. And we have up-to-date summaries of all our education programs. We're just mailing out next week the application for the Medical School Curricular Awards. So if there's anybody here that's with a medical school here in Canada and would like to do that, the programs are open to Canadian programs. We have information on retreats. We do conferences. I co-sponsor a conference with Herb Benson every year. And so we have resources posted as well. So if you have any questions or you need to email me, it's available through that website. So I'd be glad to answer any questions. Thank you very much.